Okay, can everyone hear me okay? Wonderful. Well, good morning. My name is Paige Ouimet. I'm a professor here in the finance group at the business school. I'm also the associate dean of the PhD program and the research director at the Kenan Institute. So I'm very excited for this fantastic panel that we have today talking about women's health. Women's health has clearly been in the spotlight this year given the recent court decision, but also before that we saw a shift. We saw the area of women's health become increasingly attractive to venture capital dollars, to entrepreneurs, and also to firms. We're seeing large businesses come to the conclusion that providing female benefits is important in order to best attract and retain top talent. So with this great group of panelists today, we're going to be talking about issues of women's health, what's been driving this increased interest in the area, as well as how is innovation coming to play, how is that going to change the landscape going forward. And so to get it started, I was going to ask each of the panelists to give us an introduction, both about themselves, but also about the topics they're hoping to speak to on the panel. Then I know I have some questions I'm already excited to ask, and so I'm going to go ahead and ask them. And then I promise I will also leave time to allow for some questions from the audience. So Audrey, if you would like to get us started.
Sure. Good morning, everyone. I'm Audrey Lysko. I'm a UNC Kenan-Flagler business school grad from 2011. Feels like a long time ago now. For 10 years after business school, I joined 2 different healthcare consulting firms and spent time working mostly with hospitals and health systems on various strategic and operational initiatives. And just in this past June, I joined Unified Women's Healthcare. So I'm relatively new to working just specifically in women's healthcare, but certainly not new to the healthcare space. Unified Women's Healthcare, just to give you a brief overview, it is essentially at its core a management services organization for private OBGYN practices. So it is a venue to allow private practices to remain somewhat autonomous and not, if they don't want to choose to be part of a health system. We provide a lot of the back-end services. We help provide leverage with payers because, as you can imagine, as a private practice, it's very difficult to get any leverage with the commercial payers. So we allow them to hopefully get paid fairly for the work that they do. And my role specifically is I'm a division president for the East region. So I should probably know the numbers better, about probably 600 doctors between South Carolina and Pennsylvania, all in very small private practices scattered throughout the region. We have a very large presence here in North Carolina. So if any of you go to a private practice doctor, not UNC, you're probably one of our docs. So, but women's healthcare is certainly a passion of mine. I'm really glad to see there's not just women in this room, but there's also men, because it's not just a women's issue. It really does impact all of us. I know Unified certainly has a vision to expand beyond just OBGYN, because that is such a small portion, important but small portion of what women's health more broadly can and should be. So we've made a few acquisitions recently, just a couple of weeks ago, purchasing a menopause management company, which I'm really excited about. We also have a data analytics company that really takes all the claims data from the payers, evaluates the risk, and identifies high-risk moms, and can then work with the payers to conduct interventions throughout their pregnancy to lead to shorter NICU stays, less preterm birth, et cetera, and are seeing some fantastic results just from better use of data with that. And then we also have a fertility company, so CCRM, based out of Colorado, and we're working to kind of, the vision is to how do we stitch all those together, plus additional women's health businesses to really provide that more holistic women's health care. So I'll stop there for now.
That was fantastic, and I love the call out to the men in the room. That was such a great comment. Stephanie Winans, really nice to see you guys, and really nice to see people in this room and a focus at this conference on women's health. So kudos to Erin and Zoe and the team. I'll start in terms of background so you guys have an idea of what my lens is, for better or worse. I'll start with what I'm doing now and then kind of work my way from the beginning to now. So currently I am the co-founder and CEO of a newly launched company called Iron Health. It's a collaborative care platform that is created to extend the latitude of care that OBGYNs can provide for their patients. So things like behavioral health services, as you mentioned, specialty care like chronic condition management, even the primary care needs that are really not in the purview of the OBGYN, but things that women are coming to them for in order to kind of centralize their own care. So we are taking those services off of the OBGYN's plate, giving patients the care that they want, and connecting that data for the OBGYN to have a more kind of holistic healthcare experience. And some of your comments, speak really well to what the challenges are that we'll get into in women's health, and that's part of what we're focused on addressing. I did not start my career in healthcare, though, so I always like to start by saying that, because I think a lot of us are transitioning into healthcare and trying to apply other skills, and that was certainly my experience. I started my career in digital transformation for media, which has nothing to do with health, except that the two things I was really focused on early in my career have played out really well as it relates to making an impact on the companies that I work for in healthcare. So I was doing a lot of commercialization strategy and a lot of consumer engagement strategy to drive monetization. And so I have translated that into consumer health strategy and patient engagement and growth marketing strategy for healthcare. So earlier in my career, past media, I founded a startup back in 2012. That was a maternal health, maternal and fetal medicine startup, really focused on bridging the gap for women and the prenatal journey between what we considered entertainment or edutainment and actual evidence-based health advice. That included a telehealth service, and if you guys remember 2013, no one trusted telemedicine or telehealth at that time, so I definitely cut my teeth on market maturity lessons, but I ended up selling that business to a private equity company who in an M&A healthcare roll-up rolled us into a pretty legacy enterprise healthcare company called the Wellness Network, and that was a patient ed and tech company for hospitals. So I spent 5 years there, focused primarily on their maternal health products. We had 5 products, from women's health through maternity through NICU, as you mentioned, being kind of part of that full circle, and then moved on to biodigital, which is a very innovative virtual reality and 3D interactive technology, and I was focused on launching that more heavily in the women's health point of care space. So hopefully that gives you guys a little lens. And in terms of Paige's question about what am I most excited about, I mentioned I'm excited that this conversation is happening. I'm excited to really talk about the challenges and why they're challenges. We make up half the population, so tell me why women's health is niche. Every time I hear that, it just is really mind-blowing. There's nothing else I can think of that affects 51% of the population that we would consider special. it's pretty universal at that point. So when you think about statistics and you take out the current landscape, it's kind of mind-blowing. So really happy to be here.
So I bring a slightly different perspective. My name is Caprice Greenberg. I'm the new chair of the Department of Surgery here at UNC. I started August 15th. I am a breast cancer surgeon clinically and have traditionally been involved in health services research. In 2017, I was the president of one of our major professional societies, and for my presidential address, I decided to tackle the issue of gender equity in surgery as something that was a male-dominated field, and spent about a year kind of educating myself about some of the issues around gender equity. When I was a resident at the Brigham and Women's Hospital in Boston, there had never been a woman in the program who had had a child. And it wasn't until several years after I completed my training that somebody actually had a baby, and it was when they were in their research years and not busy clinically. So that's kind of the perspective that I came from. When I was a faculty member, there was no maternity leave policy. I had 3 children, had many conversations with my chair, and he was asking me, how do we retain more women like you in surgery? And I said, you have to tackle issues around maternity leave, childcare, women's health, women's wellness. And I think that we're making progress. So in surgery now, women are about 50% of our surgery residents, only about 20% of our women in practice. And then when you look at women like me in leadership positions that can set policy, we're about 10%. So we've thought it was a pipeline, but those numbers really aren't changing. And so there's really some major issues around retention. And I think we have emerging literature showing that there's much higher levels of burnout and psychological distress for women in surgery. And then really when you pile on top of that issues around having children, it gets much worse. So 41% of female surgeons don't have children, compared to 92% of male surgeons. So it's not just that surgeons don't have kids, it's women in surgery don't have kids, and there's a reason for that. We also combine our sort of culture of bravado with stigmas around pregnancy, as well as our long work hours, and we have serious issues when it comes to women's health during pregnancy. Between 40 and 45% of women surgeons have a major complication related to their pregnancy. I personally was on bed rest with all 3 of my children. That causes more problems than if we tackle it up front, right? And then we also have higher rates of miscarriage, and all of that contributes to even exacerbating further issues of burnout. So again, women with children, much, much higher issues of psychological distress and burnout. And that leads to about 40% of women looking to leave the workforce. So again, if we want women in male-dominated fields like surgery to move up into those leadership positions, we've got to fix some of these issues. And I think hopefully during the question and answer period, we'll get into some of the ways that we're trying to address that. And we're a little bit unique from some other professions in that we do have more oversight bodies and governing bodies that can dictate policies that we have to adhere to. And unfortunately, it's kind of coming to that in terms of attacking some of these issues. Survey data from not too long ago showed that about 40% of women did not have a maternity leave policy still in their position. And that 70% had less than 6 weeks of maternity leave, and 85% had trouble getting away from their job in order to pump and be able to breastfeed their children. So that's kind of still the state of where we are in surgery, and I think it's a nice kind of case study to talk about some of these issues.
Yeah, I'll just say I'm always shocked at how poor the maternity leave policy is for health systems of all people who should know what it's like and what it takes. It's
we don't take care of ourselves, right? We're invincible.
So I was noting that both Audrey and Stephanie, you mentioned that women's health is more than maternal health. And so I guess I'd like to know more about why has the conversation shifted in that way? And then also, why has it taken so long for the conversation to shift in this way?
Okay, I'm happy to dive in first. I have a lot of opinions on this. I think there's a couple of things happening, probably why we were excited to have this panel present. Broadly in the United States, there's a big focus on diversity, equity, inclusion. Women are part of that. So I think women's health right now is having a moment just based on it being a subset of the broader DEI conversation. I think we'll get into, at least in terms of how I feel about some of the other questions coming ahead about racial disparities. When you kind of run down the list of women, there are women's challenges, and then it gets more complicated and honestly more sad when you really break that racial breakdown down and look at statistics. But the DEI landscape, I think, is part of it. The political legal landscape, and I will hold heavy comments aside, but the reality is that is driving a lot of change in women's health right now. I think that landscape presents a lot of opportunity for us. It certainly has raised the level of interest from the investment community. It is an inflection point. So while we're talking about a lot of challenges, I want to make it clear that these challenges present a lot of hope for change. And I really feel that way. And I feel that way, in practice when I'm working in this space every day. I'm trying to think, the other question you asked was around why. I think representation, like your comment about, women working in specific fields. When we think about what drives innovation, we're talking about capitalism. So what drives innovation? It's money. So when we think about where money comes from, it comes from investors. Investors are not female. And so when you start seeing representation increase, and this is not a unique comment to women's health, this is just in general, when representation increases in certain industries, you see the flow of change happen to be more representative of the entire population. So as we see more female investors, as we see more female founders like myself really out there working in entrepreneurship to drive new innovations and new business ideas forward, you start to see more focus on women's health as well. I can tell you, as someone who is always fundraising, so if there are any investors in the audience, I'd love to talk to you. But I always remark on the difference in conversations with investors who are men and investors that are women. Men do not inherently, because they're not women, understand the problem because they're not living it. And so it only makes sense that the idea of being able to relate to a problem and a solution in the same way when it's not personal to you takes more research. And so I think women, female founders, people who are out there raising capital have to really be aware of the fact that it is our duty to frame the problem for men that we are seeking investment from. Until representation becomes a little bit more equal and more investment firms have more women who can help frame up the problem, it is the duty of the people sitting in these seats to actually bridge that knowledge gap. And so I see that every day in my own conversations. And so I certainly think like the representation across the board is something that as that changes, I think we're seeing more of a flood of interest.
I'll just add two other drivers that I think are important. One is just the overall trends of consumerism, I think are really playing a role here too. And I think in a lot of ways, women are recognizing and no longer willing to, to accept just, okay, I call and I have to wait 6 weeks to go see a doctor who I'm going to spend 10 minutes with and then maybe leave with a script and then all my problems are solved. Like, no, we now know that there's so many other ways to get our needs met. And I think there's some of that, the expectations are increasing and recognizing that we need more than the traditional kind of doctor-patient relationship to meet a variety of needs. And then I think the second driver that I'll mention is there is a shortage of physicians. And it is not always, sometimes it's a matter of a geographical distribution, but overall there's a shortage of physicians. And so I think as an industry, as a medical community, we have to think about how do we leverage different care team members, health coaches, mental health, nurse practitioners, whatever, there's a host of medical clinical providers that can help meet our needs, potentially even in a better way than just your OBGYN physician can. So I think that is really forcing us as an industry to think differently about how we deliver that care that can better meet the needs of the consumer, but also just recognize that we have to do things differently because there's not more doctors coming down the pipe. We're limited, and populations keeps growing and needs keep increasing.
Yeah, I want to add on to that. I think the average wait time for an OBGYN appointment is 31.4 days, rivaled only by dermatology. So when you think about the trends for women right now are showing that kind of as the generations wane, women are using their OBGYNs as primary care physicians. So that means you have a true obstetric or gynecology issue, you wait 31.4 days. If you happen to have something that maybe is more suited to primary care, but you're concerned about the intersection of that in your pregnancy or that in your menopause or that in your postpartum period that only your OBGYN is really familiar with, you would still in your own mind as a patient, and rightfully so for the right care, want to seek your OBGYN for that. 31 days physician shortage is a really real challenge for something that's core healthcare.
And so I just want to make a couple comments on that workforce issue, and some of the ways that women's health, I think, intersects with that, and sort of gender inequity as a whole. So within healthcare, we have very serious issues with occupational segregation, which I know you people are much more familiar with than me. But women go into less well-paid fields, increase the number of people, the pay goes down. And so we have less people wanting to go into some of these primary care specialties, which include OBGYN, than wanting to go into orthopedic surgery and some of these more male-dominated, male-type work where the salaries are much, much higher. And so we have to think about some of the very deep-seated gender biases in the ways that our systems are set up that are having implications for some of these workforce shortages that we're talking about. The second piece of it is that women are scared off from some of the healthcare specialties because of all the things that I just talked about. They see women who, 25% of women end up with an infertility diagnosis in surgery, right? So our medical students see that, and they don't necessarily want to go into some of these specialties, and our undergrads see that and don't necessarily want to go into healthcare. And so when we exclude 50% of the population from people wanting to take on these occupations, it only exacerbates some of the workforce issues we're talking about.
Yeah, I want to dive a little bit more into this in the burnout question that you brought up earlier, because they're all obviously tied. And I think it also ties back to this issue of maternity leave. I can understand the issues of the surgeries. I mean, if surgeries can't be delayed by several months, how does your department handle allowing a worker to take, an extended 6-month maternity leave? What are the best practices, and how can we address worker burnout, which we know is affecting women more than men, often because of these additional responsibilities outside of work?
Yeah, so within healthcare, one of the biggest problems, right, is so after college, 4 years of medical school, and then 5 to 10 years of training, which is most of the years when most people have their children. So surgeons, the average age of your first child is 31, general population is 23. So we're delaying it during the times when we should be having children. The issues are that the way that healthcare has evolved over time is that our residents, that time when we should be thinking about having our first children, residents are the core that keeps healthcare functioning, right? And there's no redundancy within that system. And so if you lose one resident, it's a huge problem for the rest of the residency and for the department to meet the needs of the patients. And so women feel a huge burden to not contribute to exacerbating increased workload when everyone is already incredibly overwhelmed and burned out. And so we have to figure out ways to address that. There is a very important movement around APPs and expanding the workforce in terms of people that are part of the teams. I think some of the comments Audrey made are really important, recognizing we don't need physicians to do all of the work, and thinking about how we can become less dependent on physicians so that there is a little bit more flexibility. And at the end of the day, if you think about this even just from a business perspective, or a financial perspective, when we delay pregnancy and we end up with these infertility diagnoses, the increased money that we're spending and increased time that we're putting into infertility treatments really, again, sort of, it's just this vicious cycle where we keep feeding these problems on making things worse.
Okay, I think I'll shift the conversation a bit and talk about innovation. So we've seen a lot of innovation in women's health, both in terms of technology and new entrants into the marketplace. How has this innovation, and more specifically the pace of this innovation, changed how you think about women's health as a subcategory of healthcare?
I love that it's a subcategory, but I'm not sure I fully agree that women's health should be a subcategory. There's very little focus on men's health. But I think the pace of innovation is something that's exciting. And when I think about there has been an increase in innovation in women's health, there is a little bit of chicken and the egg in terms of why that is. So we talked about representation earlier. That's part of it. We talk about capital. That's part of it. But investors don't just wake up one day and decide that they're going to invest in something random. It's all very related to return. And so when we follow the money with anything that we're thinking about or building, figuring out where the money starts and where it comes from to kind of tie that to the motivator for innovation is important. I think here a lot of it has to do with policy and reimbursement. And so when you see policy that is made that supports, any kind of innovation or care, it drives more new entrants into the market. It drives investor interest because the business models become really clear and the ROI becomes really clear. And I think we see a lot of that happening right now. When I mentioned that, I see right now in this landscape as an opportunity, that's part of what I'm thinking about in terms of looking at the flow of funds, looking at, how that is going to fuel more innovation and actually make more sustainable business ideas a reality. So it's exciting to me, but I think when we think about these policies and reimbursement, and I live in DC, so I hear about more of this than I would actually care to hear about. But when we think about these things, my mind always goes to what is the downstream impact of that? There's impact on the people as a population, and there's impact in terms of how that fuels business. And I do think that in healthcare, we think about who pays, a couple of the comments that we've made already about cost to the system. Someone has to pay for all of our healthcare. That includes innovation. It's no different. And so when we follow the money and we think about reimbursement, the policy and reimbursement really has to be tied to the kind of care that people need. And we know that broadly the United States is really struggling with that, and especially struggling with that when it comes to, key performance indicators of health for women.
Yeah, and I'll just speak a little bit about some of the challenges that I see with that too, because I don't think that there's a shortage of ideas. I don't think that there's a shortage of capital. I don't think that there's a shortage of demand for a lot of these. I think the main challenges are getting it integrated into our very traditional system, and that means payers are a huge component there, and there are some niches where we're starting to bring those two things together. But then also just the traditional system. I mean, I know bringing ideas to my doctors about, how you could do things differently and actually requiring them to change the way that they've been trained, the way that they've done things is often challenging. And sometimes it's for good reason, right? I mean, they practice evidence-based medicine, and so if you don't have 10 years of research to explain why this approach is better than the way that you've been doing it, they're not really apt to change. And also, if they're not getting paid any differently to do things differently, then again, there's no incentive there. So it's really challenging when we think about actually adoption of these new ideas, these innovations in healthcare, to fight against these kind of very long ingrained systems that have evolved over time and have been effective in a lot of ways, but certainly we know there's opportunities for improvement.
And just as somebody who practices in our healthcare system, I mean, I hope everybody recognizes what an incredibly critical point we're at in terms of our healthcare system. We are in crisis following COVID for many of the reasons we've talked about in terms of workforce shortages, but also just the backup of patients and all sorts of things. And I think for the first time, there's a recognition among healthcare leadership that we have to start to do things differently. So I do think that there's more openness to innovation. There's more openness to bringing people in from the outside. Just as an example, when I was in Wisconsin, I had a joint appointment in the Department of Systems Engineering, and I was one of the only people really having conversations with systems engineers in terms of how we design work. And so they would come into the OR and just be flabbergasted at the systems and the ways that things sort of evolve and aren't designed, right? Things just evolve in healthcare in the way that we deliver care, as opposed to designing the way that we work to get the most efficient, most effective outcomes. And so I can't tell you how many times I've heard in the top leadership meetings that I'm in at this institution, we have to work differently. And so we're starting to recognize that we have to sort of open up our bubble and think differently about the way that we deliver care. This point about people not liking to change is hugely important. And I will say that there is a growing emphasis on the field of implementation science, and in particular de-implementation. So how do we get people to stop doing things that are no longer effective? Very, very challenging. I personally am very interested in concepts of coaching and how we bring coaching principles in to help providers when they're trying to make change to their practice, because most of us, again, are just trying to get through the day, just trying to meet the needs of our patients. We have these long waiting times. We're constantly double and triple booked. And so the idea of kind of taking a step back and trying to figure out how do we redesign work, we need to partner with people who do that professionally.
I think the takeaway point here about workflow from both of your perspectives is hugely important. I've done a lot of M&A in my career. I've also built some products that did not consider workflow. I will not ever make that mistake again, but having made it once and done it right a few times after that, it's workflow first, solutioning second every time, because you can have the greatest product, and you see a lot of tech companies that are core tech and healthcare second versus healthcare first and tech second fail at it every time because they have a great product, but they don't actually have anyone there who has experience working in the traditional in our actual healthcare frontline system, who understands how to actually make that happen. That's a huge mistake, right? Because it's wasted potential. And I think if there's any takeaway for anyone who is building these products, using these products, interested in investing in these products, really understanding how does it actually work in workflow, particularly when you have burnout and change management issues, not a chance. If it's a clunky workflow, it's just not going to happen.
I was going to say, when we're going out to evaluate startups to add to our portfolio, we take a team of doctors from our practices that go out and interview, and a lot of them just don't pass the tests. And that's why, right? Because they don't see how this could integrate into their practice. They're like, yeah, that's a great fancy idea. It's got a lot of cool tech. But when I think about day to day, it doesn't work. So it's a really important point.
Very interesting to think about both these challenges, but also some of these opportunities. I want to pivot to one more topic to make sure that we have time to talk about equity in healthcare. And so how do you think about some of this new innovation that's occurring in this area of women's health? And how will it come to impacting equity and expanding access?
Happy to tackle this. I'm actually spending a lot of time thinking about this right now. Mission for me and the company that I'm building now is to improve healthcare for all women. Who are all women? Actually, all women. Commercial payers, uninsured, the entire gamut. That sounds wonderful and altruistic, and I like to think that most of us who work in healthcare really have that in our hearts at our core in terms of focus. But when it comes down to actually building a business that works, that can be really tricky. And so I think what I see a lot of times and what I am grappling with right now is making that happen from a financial perspective. And so it has to be baked in from the beginning. If it's not, and you think about layering on solutions and starting, top of market, so to speak, with commercial payers, it actually becomes harder to figure out how to make that model work for Medicaid and uninsured patients. And so if it's not baked in from the beginning in terms of a business model standpoint, it just doesn't happen. I do think that, we've talked a lot about, or I've talked a lot about where the money comes from. And I think when we think about policy and reimbursement and government programs, there are a lot of good things happening that are helping companies that really want to make this work, that are providing the funding to make that possible. It requires creativity and really thinking hard about funding sources sometimes, but it is a real challenge. And I think it's a real challenge because it's not just the right thing to do, but it's also what has to be done to change the landscape of women's health. Like, we didn't really set the stage on how bad things are, But things are really bad. If you look up the United States and you look up really bad, what does that mean? It means that it would embarrass you to actually be a citizen in the United States serving women with this kind of health care when they make up half the population. We fail at pretty much every health outcome KPI, and we fail in a way that puts us, down with developing nations in terms of our outcomes versus, at the top of the list, which is where you would expect us to be. And, we mentioned racial disparity, which I think is tied into this access conversation. To drive outcomes forward, you have to tackle the people who have outcomes that are the poorest to really move the needle. And so when we think about where, how that kind of layering looks like, there are problems for all women. The racial disparities, when you kind of break that down, they look really rough. Black women are 2 to 3 times more likely to have a maternal mortality, to die in childbirth, than white women. That is huge. Why is that? I'm not really sure. That's why we haven't fixed it. It is very, very systemic. And when you think about those things and you tie that back to your question about innovation and access, we have to be willing to, one, make business trade-offs to really make an impact in healthcare. And that's, I am both a person who loves the idea of driving outcomes, and I also love profit. So finding that balance can be really tricky. We have to make sure that when we're voting, we're looking at policy that actually drives the ties to healthcare forward. And I think we have to think about access from the beginning for people that are building solutions and people that are providing care, and I'd love to hear your perspective too in terms of research on equity you mentioned. I mean, this is a broader topic. We could have an hour just on that, but I'd love to hear your thoughts.
Yeah, no, for sure. And I think that the way that our healthcare system is set up and the way that it is moving from a financial standpoint has serious risk of worsening our inequity. Right now, it is just not financially feasible to run a hospital the ways that things are and meet your mission if you're a mission-driven organization, because we have no way to get reimbursed for the care that we provide to people who don't have insurance, who have Medicaid, who have these sort of low reimbursement rates. We just can't cover our costs. And that's getting worse and worse. And I think what we're seeing is more of those patients shipped to places like UNC because outside private hospitals are paying more and more attention to their bottom line, which is getting narrower and narrower. And the problem is UNC doesn't get state funding. So it's not like we have some government funding coming in to help us support the population that's not insured. And so we're somehow supposed to make all of the pieces fit together, which is nearly impossible to do. And I think one of the ways that they're trying to tackle that from the payer perspective is in some of these alternative payment strategies. They're trying to incorporate some measures of equity as some of the quality metrics by which your payment is determined. But again, you can do that and it can try to motivate you, but the financial implications of that are really can be very devastating and challenging. The equity piece is really an interesting one, and I think as we start to think more and more about equity as a component of population health, I think we're getting more attention to that. And I think in particular, having been in Wisconsin, Georgia, and now North Carolina, there are some major similarities in those states in terms of the politics, as well as in terms of sort of the rural-urban component, and there's a big interest in sort of rural-urban disparities in care. And I think in the South, one of the things that has really struck me is sort of the intersectionality of the racial disparities as well as the rural-urban. And I think that trying to think about how we develop more systems that are statewide to tackle how people access care is going to be really important in how we get just more coordinated in what we do. And to me, that's one of the reasons I wanted to come to this place and why I've always worked at a state academic medical center, is because I think one of our moral responsibilities is to the people and the population of the state to figure out how we make sure that everybody gets access to the most highest quality care they can.
I'll just add from the private practice perspective, a lot of our docs don't even see Medicaid patients. And, that's not something I'm necessarily proud of, but again, it's their small business. They get to make the decision, and it's because they don't make money. And they are small business owners, and, that they, eat what they kill for all intents and purposes. So if in a fee-for-service model, they lose money. And they also, most of the time, those uninsured or Medicaid patients actually require even more resources, which they don't even have. So they don't have, they're not a health system. They have a social worker down the hall or whatnot. They can maybe, the checkout person can give them a card of an agency nearby that they can call, but they're not equipped to deal with those patients. And so where do those patients go? I mean, sometimes, I guess, if there's an FQHC network close by, they can go there, but our system is not set up to care for those patients, and until we fix that, the inequity is going to persist. I think value-based care is the only maybe light at the end of the tunnel, but making that actually work, I don't think we're anywhere close to figuring that piece out. So it takes you to a dark place when you stop and think about it for too long.
Okay, well, so no easy solutions. But at least we're having the conversation. But obviously we need to go beyond just the conversation to move the dial on this. I did promise that we would take questions from the audience. So are there any questions? Looks like we've got one back there.
So two questions. One of which is, I think that the reimbursement question is a two-sided question. A lot of organizations are demanding increased reimbursement without the increase in transparency of their cost structure. And so I think what you see from a payer perspective, what you see from a public perspective, is a cost structure that where you're pumping more additional funds into a system that is a black hole, right? And health systems, when pushed for transparency, push back. And so how will there be a level of transparency? Because I don't think that there is a lack of desire to add additional costs to address some of the inequities that are out there. But there's a desire from the lack of the health systems to show a level of transparency to say where they're spending the money to impact care and health. Two, I just want to correct you on the idea that UNC doesn't receive state dollars. UNC receives disproportionate share. UNC receives supplemental payment program. UNC receives several dollars to treat uninsured and underinsured patient populations at the state and federal level. But again, there's a lack of transparency that is expected and ask for additional funding without a lack of transparency. My question to you guys is how do you plan to provide additional transparency so that organizations that are interested in putting money into this can see where their dollars are going towards care?
Paige, can you repeat the question for those who are online and then we'll hear it without a microphone?
That was a long question to repeat.
Challenging time.
What it's basically saying is part of what we need to know is people want to spend money on healthcare. They want to know what they're spending on.
How can we increase transparency in the system? Anyone want to take a stab at this one?
I'll just say, not my unified experience, but my previous health system consultant had on. I think you bring up a really great point. 10 plus years working with health systems, it was unbelievable to me that they couldn't tell you how much anything costs ever. Like it's almost like that would not fly in any other business setting, right? You can't, I know there's a lot of efforts around price transparency and like we're getting there, but we're at the tip of the iceberg, right? I mean, you can't very easily say, hey, I want to have my right knee scoped. Like, what's your cost for that? What's your cost for that? And because they don't, and it's not that they don't want to tell you, they don't know. They don't know what it costs them, and so it's really hard. And there's a lot of reasons for that. I think the payers cause a lot of challenges with that too, because everybody's plan is different and depending on what plan and negotiated rates, and it's a very, very complex web that we've woven, which makes it very difficult for the hospitals to actually understand what their costs are and allocate those costs appropriately. So I don't have any answers, but I think that's a real concern.
Yeah, and I apologize if I misspoke on UNC. I've only been here for 3 months. But, again, what I meant more was there are certain states where institutions get dollars directly from the state to help run the hospital that are not tied to individual patients. So you are correct that there are additional dollars that go to certain types of patients, but it's not like we have underlying support the institution, which is different than institutions that I've been at previously. So thank you for that clarification, because it is an important one. Listen, I can't express to you the amount of frustration that I have about the lack of transparency about costs in healthcare, right? I'm a department chair. I'm not a hospital administrator. I'm responsible for trying to run a department. we are just getting to the point where we're starting to get clarity about costs for procedures so that I can even go to my surgeons and say, it costs you $1,000 more to do this same operation than this person. How can we look at that and try to navigate that, right? So we are flying just as blind, I think, as payers are, and are just as frustrated by the lack of transparency around cost. And I think some of this has to do with, again, healthcare has been very isolated, and we haven't necessarily developed as the rest of the world has developed in terms of business and finances and all of these things. And now we're in a point where we're in financial distress as a discipline, as an entity, as a part of our society, and it's very hard to think about the amount of money that we have to invest in bringing business minds into healthcare to try to sort out sort of the mess that we've gotten into. Again, I'm not making decisions as an administrator at all. I'm a user, I would say, internally, and I just want to echo the frustrations that you've expressed. I think we all feel it on both sides.
Okay, so we have 5 more minutes left. I want to give each of our panelists the opportunity to give some concluding remarks. So just a general prompt would be thinking about where do you expect in terms of women's health to change going forward? But otherwise, if you want to add any more comments about the discussion, Audrey, if you want to get us started.
I envision a world in the not too distant future where we are very much leveraging a more broad and diverse set of caregivers to meet needs and more better defining different areas of opportunity to get those needs met. I know the company that we just acquired is called Genève, the menopause management company. It's just fascinating to do some research on the way they've thought about it. You know, every woman who's fortunate enough to live past the age of 40 will likely experience, will experience menopause. So it is not a niche industry, and it is something that is very undermanaged and significantly impacts mental health, productivity, men, women alike. So certainly more opportunities like that to manage outside of your traditional doctor-patient relationship. I think we'll start to see a lot more of that emerge. And then I also wanted to give everyone a book recommendation. If you haven't read it, our CEO handed us this book recently, and it's called Sex Matters. And it's written by an ED physician from Brown who just kept seeing disparities as patients were coming into the ED, and then basically devoted the rest of her career to research about how so much of the research in medicine has been on men, and therefore conclusions have been drawn that don't necessarily apply in the same way to women's healthcare. So it's certainly worth a read.
Thank you.
I'm glad you recommended that, because my vision is kind of a world from soup to nuts where women and special interests for women are considered. So from med school and medical illustration and anatomy training and all of the things that build providers that are more educated about women's special interests through to clinical trials and actually testing drugs and treatments specifically on women, through to policy, through to reimbursement, through to the care and the way we provide care and the intersection of specialty care and true obstetrics and gynecological care, kind of through the full spectrum that we actually just consider and build it into everything. How is this different for men than from women? And so that would be kind of the future that I envision, and I think that in and of itself would drive a tremendous impact to outcomes.
And I guess there's 2 things that I would that I would highlight. One is I think that there's a shift in healthcare from being reactive to proactive, and an increased focus on wellness as opposed to just reacting to illness, which I think is very helpful and does apply, I think, to women in particular. And I do hope that that's going to drive more of our policies. And then I think the second piece of it just is this focus on the increasing recognition of the importance of making sure that women's needs are accounted for in the workplace in terms of benefits and policies and other things. I think that we're making a lot of progress, and I'm hopeful that that will help to retain more women in the workforce.
Wonderful. Well, if we can all thank our panelists.
Thank you, guys.
We managed to stay away from that. So.
If you would like to see the quest for value creation through M&A in the healthcare industry, please stay here. And if you would like to watch the next panel, the B panel, Entrepreneurship and Health Equity, How Innovation Can Drive Change, please head over to Kenan Center 204. Both panels will start in 10 minutes.